Good afternoon, everyone, and welcome to the TxRx Medications for Substance Use Disorder Echo. Please note that we are recording these sessions for later distribution. Anything listed in the chat does not appear in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat. You can access it by clicking on the speech bubble icon on the navigation bar, the bottom of your window. If you are one of our BWell Texas providers, please make sure that you identify yourselves during the session. If you are joining via phone, please email your phone number and name to bwelltx@utisca.edu. Some housekeeping, please stay muted unless you're speaking. If you've joined by the computer, your mute button is on the bottom left of your Zoom controls. If you are on the phone, just press *6. We encourage everyone to speak at these sessions, especially during the discussion portion of the session. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. You can also use the chat feature to share comments and questions. Please note that no protected health information is allowed in either the chat or the discussion, and that includes names, emails, addresses, dates, or any information that can easily identify an individual. If you would like to view closed captioning, please navigate the bottom of your Zoom window and select the Show Captions option. Towards the end of the session, the BWell Texas team will send out a link to an evaluation survey. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on co-occurring mental health conditions and substance use disorders and will be presented by Dr. Eric Parmon. Following that, we will discuss a case presented by Dr. Ralph Luckner. We'll start with some introductions, followed by didactics, BWell program announcements, case presentation, and open discussion. Thank you all again for joining today's Echo. We look forward to learning alongside you and encourage you all to share your experiences and insights in today's conversation. And with that, we will do some introductions. Dr. King.
Hello, everybody. I'm Van King. I'm the BWell Medical Director. I'm a professor, UT Health San Antonio, and glad to be here. Hello, everybody.
Thank you so much. Dr. Walker.
Hi, good afternoon. Crystal Walker, doctorally trained PA, and I am the Director of SUDS Clinical Services at My Health, My Resources of Tarrant County in Fort Worth. It's a mouthful. I sometimes forget my own title, but welcome, everybody.
Thank you so much. Dr. Kowalczyk.
Hi, Alicia, Dr. Kowalczyk. I'm with Baylor College of Medicine, and I'm medical director at Santa Maria Hospital.
Thank you so much. Dr. Parmon.
Hi, everybody. My name is Eric Parmon. I'm currently completing a T32 Addiction Psychiatry Research Fellowship at Columbia University Irving Medical Center.
Thank you so much for joining us today. Dr. Luckner.
Hello, I'm Dr. Luckner. I'm a primary care physician in the Texas Panhandle. I do OBOT and also mental health. I'll be presenting a case today.
Thank you so much. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal, and I'm the TxRx program coordinator. Thank you for joining us today.
Thank you. And with that, we will get started with our didactics. Dr. Parmon, you can take it away whenever you're ready.
Thanks. All right. Hi, everybody. Hopefully you can see this screen okay. So as I said already, my name is Eric Parmon. I am a psychiatrist. I actually did my psychiatry residency at UT Health San Antonio, worked for many years with Dr. King, learned from the best. So today I'm going to be talking about treatment for co-occurring psychiatric and substance use disorders. And it's going to be a bit about medication treatment in particular. And I wanted to make a fairly bread and butter presentation because, as I understand, there are many levels of learners here. So forgive me if you're already an addiction psychiatrist, you may already know all this stuff, and that's okay. All right, I don't have any disclosures to report. for better or worse. Okay. So learning objectives, I want us to be able to identify co-occurring psychiatric and substance use disorder conditions, and develop an overall treatment framework, identify specific treatments that can be helpful to manage them. All right, so in terms of the etiological theories of co-occurring disorders, and so what causes what? There's a couple of different strains of thought and not really a consensus on what is doing what here. So one thought is that there's something for an individual, if a person has co-occurring psychiatric and substance use disorders, maybe there's something that happened upstream to both of them earlier in their life, for instance, that caused both to happen. There's another school of thought that, at least for some people, that substance use disorders may precipitate psych disorders in people who are particularly vulnerable. And of course, as a person deals with the consequences of their substance use disorder and the disarray that often causes, it not uncommonly leads to depression, major depressive disorders, etc. There's for one school of thought that it goes the other way, that sometimes people already with a psychiatric disorder might use substances and develop a substance use disorder to deal with the symptoms or deal with the side effects of medications. And probably for many people, it's bidirectional, right? And so they're mutually reinforcing. A psychiatric disorder can precipitate a substance use disorder and vice versa. So substance use disorders, they're very common. Many people with substance use disorders, particularly opioid use disorder, particularly women with opioid use disorders, have traumatic histories. Upwards of, the prevalence varies, estimates, but almost 80% based on some estimates. And trauma history often can lead to or contribute to post-traumatic stress disorder with people who are vulnerable, or may contribute to development of personality disorders, particularly borderline personality disorder. And as I mentioned, active substance use disorders, they not uncommonly create conditions that contribute to anxiety and depression and psychotic disorders, or mood disorders, bipolar related disorders with stimulants. And so, as you can see, they can really go in both directions. And there's a very large percentage of people with substance use disorders who have some kind of diagnosable psychiatric condition. So it's important to be able to recognize and treat both. So some general treatment approaches, it relies first on a good clinical evaluation. You have to know that the patient has these things to be able to treat them. As with any sort of treatments in terms of substance use disorder, and I would argue psychiatric disorders, motivational interviewing is a very key piece of this, and developing a patient-centric plan. So it's really hard for a person to address their substance use disorders if they're dealing with housing or food insecurity, for instance. So dealing with basic needs is often a very important part of the plan. Oftentimes psychotherapy is indicated. For some substance use disorders, that's the best treatment we have, unfortunately. We don't have some medications for certain substance use disorders, like good ones for cannabis use disorder, for instance, that are FDA approved. Pharmacotherapy can be helpful, and addressing their physical health needs. All these are important to have a general treatment approach for people with co-occurring disorders. And successful treatment depends on you being aware that they're dealing with these things. You can't treat something if you don't know it's happening. And part of that is you have to, and you and the patient both need buy-in for the treatments. If you're giving them a prescription and this is what you think will help them, but this isn't what they think will work for them, and they don't have buy-in, it's probably not going to work. And also, you're going to have the best thought for a treatment, but if the person doesn't have access to the treatment, then it's really not going to work. If they can't afford the medications, if they can't manage to get to the clinic during normal business hours, et cetera. All right. So this is very, very broad, and sorry, this is a busy slide, but so just psychiatric treatment in broad strokes. So this is psychiatry residency condensed into a slide. So in general, and this is a gross oversimplification, so we can think of treating psychiatric conditions by the condition itself. So depressive disorders in broad strokes, anxiety disorders, trauma-related disorders, ADHD. And there's certain classes of medications that are evidence-based in general for the overall condition. So for depressive disorders like major depression, SSRIs are the classics of selective serotonin reuptake inhibitors, atypical antidepressants, and of course there's therapy such as CBT, which is a mainstay. However, we can also think about treating by symptom. And this is important because sometimes when you have a person with co-occurring disorders, you're dealing with symptoms. You have maybe a general sense of what the psychiatric condition is, but your formulation is not completely set in stone. It's hard to tell sometimes if it's a process. Maybe you're dealing with withdrawal and that's causing some of the anxiety or insomnia, or if it's a substance-induced depressive disorder, for instance. And sometimes you're dealing with symptoms. And so there's certain medications that we can think of that in broad strokes treat those types of symptoms. And of course, it's going to be really important to have an overall formulation and an idea of what you're treating. So it's, you can say, okay, well, this patient has insomnia. I think it's primarily related to withdrawal, and that's my conceptualization, but maybe it's related to a depressive disorder or maybe some of both. And so you can rationally start to pick some of these medications that might help. Similar thing with substance use disorders. So again, we can have treatment by condition and treatment by symptoms here. So I've bolded the ones that are FDA approved, like the gold standard treatment. So for instance, for nicotine use disorder, the gold standard treatments, we have nicotine replacement therapy, we have bupropion. You can combine both. And we have varenicline, which are all very good treatments. For alcohol, treatments are maybe not as good, but we do have some FDA approved ones. We have disulfiram, naltrexone, and acamprosate, which are the FDA approved ones, but there's also many things that can and are often used off-label, for instance, gabapentin, topiramate, baclofen. Baclofen, there's like a little bit of evidence. That's why there's a question mark for some of this, but it's not a very common treatment, and it's not a very strong evidence base. For opioids, we have basically the best treatments, the biggest effect sizes out of all of the substance classes. So we have naltrexone, which of course comes in an oral formulation, and a long-acting injectable, methadone and buprenorphine, which also comes as a long-acting injectable too. For stimulants, we really don't have great medication options. There are some studies out there that do support using like psychostimulants, like for instance, mixamphetamine salts, lisdexamphetamine, for treatment of cocaine use disorders. There is a study coming out of Texas from Trivedi that really, it was a good solid evidence base for perhaps considering treating methamphetamine use disorders with naltrexone and bupropion. For cannabis, we, again, don't really have any FDA-approved treatments. There's some evidence that maybe N-acetylcysteine can be used, and that seems like the evidence base is stronger in adolescents versus adults, not really replicated very well, some of the findings in adults. And we have modulators for the CB1 receptors, for instance, like nabiximols, that there's some evidence for it. There have been some studies, for instance, for gabapentin, has some preliminary evidence, but in general, what we can also think of is treating by symptoms. So the main kind of targets that we can think of is we can target the cravings and we can target the withdrawal. And so to target the cravings, oftentimes that's how we think maybe naltrexone. One of the reasons it works for conditions like alcohol use disorder. yeah, N-acetylcysteine, as I mentioned, that's thought to kind of work on cravings, maybe bupropion, particularly for nicotine. Oftentimes your patients will report that they just don't feel as much like they don't have as much desire to smoke. We have the GLP-1 agonist. Maybe there's some preliminary evidence and certainly anecdotal reports of Ozempic, and oftentimes people who are taking Ozempic, they report decreased cravings for substances. And then the other broad category of symptoms that we can think of treating is withdrawal. So very commonly, the main ones for withdrawal are anxiety and insomnia. And of course, each substance class has a different withdrawal phenomenon, but these are very common and pretty well represented amongst substance classes. So for anxiety, you have your antihistamines like hydroxyzine, you have your GABA receptor ligands like gabapentin, buspirone, clonidine. And for insomnia, we have our atypical antidepressants like mirtazapine, trazodone, and then we have some of the second generation antipsychotics like quetiapine. Hydroxyzine can work for that too. And so effective treatment planning, again, just to hammer this point home, you got to know that what you're treating, and the patient has to have buy-in. And one reason it can be helpful to talk about symptoms and managing symptoms is because that's often how the patient, how the person will talk about it. Why are they using the substance itself? Oftentimes it's to deal with some of these symptoms. They feel terrible when they go through withdrawal and that they can't sleep. And for instance, with cannabis use disorder withdrawal, it's like, yeah, classically a person can't really sleep very well. They can't eat. And so that could be why they use, or one of the reasons that they use cannabis is to deal with some of those symptoms. And to talk in terms of symptoms and getting on the same page is like, yeah, we're going to work together to deal with some of these symptoms. And that can go a long way to having buy-in for treatments and to be collaborative in that process. But as I mentioned, it's easy to get into the weeds if you're just chasing symptoms. So it's important to also have a diagnostic formulation behind it. So yeah, maybe a person has anxiety that we think maybe there's a standalone anxiety disorder behind it too. And it doesn't seem like they have a bipolar disorder. We screen for that. And so there might be good rationale to treat in the short term with something like hydroxyzine, but also at the same time starting a longer term treatment like an antidepressant. So some specific treatment issues, things that sometimes I've encountered is that for some people, there's nervousness to use varenicline for smoking cessation. For a person with a depressive disorder or mood disorder, because of this previously documented concern for mood and suicidality. It used to be a black box warning. It is no longer a black box warning. About 5 years ago, there was a seminal trial called the Eagles trial that showed that essentially there were no worsened neuropsychiatric side effects from these medications with people with mood disorders. So it's a relatively safe medication. Of course, there's always risks and benefits, but I think varenicline is very underused. And oftentimes in this population, that's one of the reasons that there's this misconception that there's a black box warning. There's not. For naltrexone, if we're thinking of opioid use disorders or alcohol use disorders, or maybe even a stimulant use disorder, oftentimes people are really nervous about the liver enzymes. Transaminitis is not an absolute contraindication. And I think that some people, they are a little too cautious that if it's out of reference range at all, they shy away from using naltrexone. There's some evidence that suggests, and certainly clinical practice too, that it's reasonable to consider initiating treatment if the liver enzymes are within 5 times upper limit of normal. And of course, you want to check that again to make sure it's trending in the right direction. But don't necessarily think that you can't prescribe naltrexone if a person has some liver abnormalities. For stimulants, Yeah, let's say you have a patient with ADHD and stimulant, or rather, and a substance use disorder. Some people think that it's an absolute contraindication that, oh, no, I can't ever treat with a stimulant, and that's not true. So there's actually good, strong evidence base that with ADHD co-occurring with substance use disorders, it improves overall outcomes. It improves treatment retention, adherence to treatments, all-cause mortality in some studies if you treat the ADHD, including with the stimulants. And of course, you need to think through the risks and benefits, but I would argue that it's important to consider treating ADHD. A couple other points. So integrated and simultaneous care is generally better than separate care, fragmented care. So let's say you're an addiction medicine physician or provider, and you're treating them for opioid use disorder, and you're treating them for their hepatitis, and you also are concerned that they have like a major depressive disorder or a trauma disorder. It will be better in general if you yourself are able, or within your clinic in an integrated way, to treat them comprehensively versus referring them out, because more appointments, more logistics, more fragmentation of care. Oftentimes providers don't communicate very well about care coordination. It can be expensive. All these issues can contribute to a person not receiving adequate care. And importantly, I think the evidence is very clear that it's important to treat substance use disorders co-occurring with psychiatric use disorders concurrently. So treat them at the same time. Don't delay treatment until you deal with one to deal with the other. It's important to treat them simultaneously. Of course, it's important. I'm not saying that you need to manage absolutely everything under the sun yourself. Of course, it's going to be important to appreciate things that require a higher level of care, like suicidality, mania psychosis, imminent complicated withdrawal, or other medical conditions. Another couple of things. I know I'm short on time here, but keep in mind, substance use does not equal a substance use disorder. Just because a person uses substances doesn't mean that they meet criteria, so don't assume. And if your goal doesn't meet the patient's goal, then generally the work is to find common ground and get on the same page. And the best treatment is the one that the patient actually wants to do, usually, or actually does. In terms of psychotic disorders like schizophrenia, really consider long-acting injectables when possible. That's also true, and I think for alcohol use disorders and opioid use disorders, I really am an advocate for long-acting injectables, like the long-acting injectable form of naltrexone or the sublocade. And it's okay to play the long game. Yeah, just get them over the hump with some of these symptoms, and with the goal to keep them in care and treat them and have them come back to you, because the goal is to reduce harm. So putting it all together, and we've talked about a lot of this already. And so this is just kind of summing up what we've talked about. So screen for things, use screening tools. There's common ones. I know one that we're using, the New York State Office of Addiction and Support Services. They've started using the ASSIST screening tool for substances. I'm not saying that that's the best one, but there are many screening tools out there that can help you identify substance use disorders and psychiatric disorders. Collaborate and really work together with the people with substance use disorders. Offer evidence-based treatments, and hopefully I'm hoping that a person who treats substance use disorders, even if you're not psychiatry trained, you can still treat uncomplicated depressive disorders and anxiety disorders, mild, non-acute mood disorders, if they're not forwardly manic or forwardly psychotic. I think that that's fair game for a person, hopefully, to be able to treat, even if you're not a specialist. And of course, the other way, yeah, I'm hoping that everybody on this call, if you're a prescriber, can manage treating co-occurring disorders in terms of the substance side with varenicline, alcohol use disorder, opioid use disorder. And then, yeah, treat some of the side effects of the withdrawal phenomenons. It's okay to think of, let's say, if a person has major depressive disorder and a substance use disorder and insomnia, maybe think of using mirtazapine, trazodone. If instead of a major depressive disorder, you think they might have a bipolar disorder, maybe think of like quetiapine or olanzapine. If they have an alcohol use disorder with anxiety and insomnia, you can think of gabapentin. And really, the goal is with rational pharmacotherapy, knocking out multiple birds with one stone. So if they have like a tobacco use disorder and a major depressive disorder, think about maybe bupropion in that situation, or an anxiety disorder and alcohol use disorder, maybe gabapentin might be a reasonable choice. And that's kind of what I'm trying to convey as a take home for rational pharmacotherapy. Here's like just some common ones to really help get them over the hump. Clonidine, I think it can be used for anxiety with or without withdrawal. Gabapentin might be a good choice. Hydroxyzine, Seroquel for a short term, even if a person doesn't have like a schizophrenia or a bipolar disorder, it could be enough to get them through some of the withdrawal. And the goal is to temporize them while initiating some of the more durable treatments, like the gold standard substance use disorder treatments, psychotherapy, SSRIs, mood stabilizers, antipsychotics, etc. Yeah, I'm talking a little bit too long here, so I'll skip this slide here. And here's just some examples of like a simple plan, for instance. So this is the last slide. Oops, I didn't mean to advance that. Sorry. Here, there we go. Yeah, so for instance, if you have like an overall medically healthy patient meeting criteria for major depressive disorder and alcohol use disorder, complaining of anxiety, you're not sure if it's meeting the criteria for standalone anxiety disorder, yeah, of course, screen them for a higher level of care, the imminent suicide risk, complicated withdrawal. And then maybe if you're satisfied that you can treat them as an outpatient, you might consider something like escitalopram, 5 to 10 milligrams starting off, and then maybe some naltrexone and gabapentin all together with a plan to follow them up pretty closely, keep doing motivational enhancement, motivational interviewing, check for side effects, check for, make sure that they're getting some benefits. You're going to try to clarify the diagnosis over time. And if it seems like maybe the anxiety remains after you're treating some of the withdrawal, and perhaps you think that they have an anxiety, like standalone anxiety disorder, you can refer them to CBT, for instance. Similar with cannabis use disorder, let's say if you have a person with a cannabis use disorder and they have like some mild psychotic symptoms, maybe you're not sure if it's cannabis induced, maybe they're in their 20s. Is this unmasking of a primary psychotic disorder? Maybe they're smoking as well, which is very common, and they can't eat and they can't sleep when they try to stop. So consider, as I said, varenicline. There's not really a black box warning for suicidality. It's okay to use it. Maybe consider starting them on some quetiapine, 50 milligrams. Follow them up closely. Consider titrating quetiapine. You're going to engage them in motivational enhancements. And then over time, if it appears like, hey, they're not using cannabis, but they still have some psychotic phenomenon, I'm thinking that maybe this is a primary psychotic disorder, you might consider switching to a medication with a long-acting formulation. You might consider assertive community treatment, family-based intervention, skills training, etc. So the overall takeaway is, I hope from this that even if you're not psychiatry trained, it's not scary to treat some of these things, and your patients will do better for them. So happy to take some questions. Sorry, I ran a little bit over on time.
Thank you so much, Dr. Parmon, for this wonderful presentation. We do have a couple of minutes for some questions from our learning community here.
Great. Are there questions in the chat?
Yeah, I just see a question here from Vanessa Fierce. What is your opinion on orthomolecular treatment for individuals struggling with alcohol use disorder?
I can't say that I really have read the literature based on that. I mean, Yeah, I'll be curious to read more about that. Yeah, I actually don't really have an opinion on that. I don't know if maybe Dr. King knows more about it than I do, but yeah, actually, I don't have an opinion. Okay, vitamin. Yeah, I mean, so like things like N-acetylcysteine can be considered in some way like a supplement. Yeah, the tricky thing with doing anything on evidence base is you have to have money to do the studies, and if you're trying to do like vitamins and minerals, it's hard to get a pharmaceutical company to want to push for that, which is oftentimes how these studies are done. So the trick is that like if we're really trying to do evidence-based medicine, it's hard to do those studies. And at least for some of these things, I haven't read very strong evidence-based supporting them. I mean, there's some anecdotal evidence for some supplements, but it's just they're hard studies to get funded, unfortunately.
There's another question from Kristen. Any thoughts on buspirone? Has any data on tirzepatide and AUD been released yet?
Yeah, so buspirone, I've at least anecdotally used it with some success. I think oftentimes people who tend to respond to it tend to respond at higher dosage in that dose range. You know, some people, of course, you'll encounter opinions like, oh, it's kind of like a placebo. But I actually, at least my own practice, I have had people respond to it. So don't roll it out. I think overall, people tolerate it fairly well. There's not a lot of risks involved in using buspirone, so it's something to consider. But maybe keep your expectations modest. And then I haven't seen any of the data on tirzepatide. Yeah, that's a mouthful. I know that some of these studies are ongoing, but yeah, I haven't actually seen any of the data if it's been released yet.
Dr. King, you had a comment to make, I thought at some point.
No, I was just going to say, thanks, Dr. Parmon. That was great. I just saw a comment. Somebody, commented they really liked the way you broke it down and made it very sort of rational. I think we don't often see that approach, and I think especially for a broader audience, that is a nice way to present it, so that people have some way to hang their hat on, why patients may be on these various medicines.
Yeah, thank you.
Thank you so much. This has been a wonderful discussion. Please keep your questions coming in the chat, and in the meanwhile, we will move on to the next part of our session today. Kato, if you could please bring up the announcements. Thank you. To claim the CME credit, you must text by midnight tonight. Please text attend to 100-957-37 to 844-502-1338. You must register for each session. You must text for each session by midnight to receive the CME credit. Next slide. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization may be facing and receive feedback from our hub of experts and the broader learning community. There is no need to prepare a formal presentation. We will be sharing a case form with you to help with the presentation. Please email cstat@utisca.edu. Next slide. The Center for Substance Use Training and Telementoring, CSTAT, offers technical assistance for various substance use disorder needs and topics via our team of experts. To request technical assistance, please complete an online request form. You can use the link in the chat. Next slide. Our webinar series, Thriving in a Substance Use Disorder Service Delivery in the Post-COVID Era, will be presenting recognizing COVID-19 related compassion fatigue and enhancing provider resiliency. This is tomorrow at 12 noon. Please use the link in the chat to register. It'll be a great session. Next slide. And please join us for our next TxRx Echo. This will be on Tuesday, May 21st at 12 noon. With that, we will move on to our case for today. Dr. Luckner, you can take it away whenever you're ready.
There, it helps if I unmute. So coincidentally, I have a case of a patient who has both substance use and mental health issues. I'm going to be focusing on an area that I don't normally focus on when I'm treating patients, and that is how to improve treatment of a male patient with opioid use disorder who's romantically involved with a female with opioid use disorder. One of my staff actually brought this up as something that she felt like his girlfriend was holding him back. So I just thought I'd look into that and see what the literature says. And just to give a little bit of background on this patient, he has a substance use history in terms of, he does use nicotine, binges on alcohol, abuses methamphetamine. In our area, in the Texas Panhandle, we do have MDMA in the meth. Heroin, he's used it in the past. He smoked it. Opioids, fentanyl's popular these days. He's been using that. But no hallucinogens, inhalants, no benzos. But he did take some methadone recently. He and his girlfriend went through rehab, and they have supposedly not used any opioids since December 4th. Although I did detect methadone, for the most part, I do think that they're being compliant. In terms of substance abuse counseling, he's had it in the past. He's getting it in the present. He's had inpatient treatment in inpatient rehab. He's not currently inpatient. I'm using the WeConnect app with my patients. So he's using that to get mutual support and peer support. And then as far as medication use for opioid use disorder, we have buprenorphine that we're prescribing him, and it's also funded by Be Well. Although methadone is not part of his treatment, he has used it at least once. I'm not using naltrexone. I've checked the PDMP, and he hasn't had any opioids prescribed to him. And he's had some benzos in the past prescribed, but that was about it. Depression, he does have major depressive disorder, moderate. Also, he's having a lot of financial problems, so he's able to afford the buprenorphine because it doesn't cost anything for him. But any other medications, even if they're a little bit of money, he just says he can't afford them. Self-medicates with meth, and then he doesn't have mania. I don't detect any PTSD, OCD, or panic disorder, no psychosis. He does have ADHD, and he self-medicates with meth. As far as the DSM-5 criteria are concerned for his substances, fentanyl and methamphetamine, he meets criteria in terms of substances taken in larger amounts over a longer period of time than intended. For example, it's not unusual for me to see people who are taking, 4 or 5 grams of fentanyl and using a lot of meth. And then persistent desire or unsuccessful efforts to cut down or control substance use. A great deal of time spent in activities to obtain the substance has been more so in the past than current meth is readily available. Doesn't take a lot of effort to get that. It's also cheaper than pharmaceutical medications, apparently. Cravings, he does have that, and that's one of the reasons that he wanted the treatment with buprenorphine. And also a recurrent substance use and failure to fulfill major role obligations at work. He's not been able to hold a job, and continued substance use despite having persistent recurrent social or interpersonal problems. That's also an issue, particularly with the parents, his parents and her parents. As far as important social, occupational, recreational activities, given up. it's a yes, but he does have some hobbies. Recurrent substance use in the situation, which is physically hazardous. He has had a overdose about a year ago. Continued use despite having persistent recurrent physical and psychological problems likely caused by the substances. I couldn't really tease that out as well. And then tolerance definitely has that. Withdrawal was a big motivation for using buprenorphine. So one thing I'm finding with people who are using high dose fentanyl is I have to use pretty high dose buprenorphine to control their cravings. It does seem to become less of an issue over time, but sometimes it's hard for me to know exactly how much to prescribe, other than I want to make sure that they don't have cravings and they're not, still having cravings and then getting methadone or other substances. I want them to just use buprenorphine. He's using rivaroxaban. It's also called Xarelto is a brand name. The dose is 20 milligrams per day for clotting disorder. He also has been prescribed Lexapro, escitalopram, but he's unable to afford it. Adderall, again, I prescribed that to him, but methamphetamine is a lot cheaper, and he hasn't been able to afford the Adderall. Warfarin is a sort of an emergency substitute for in case he runs out of the rivaroxaban. I prescribed that for him. It only costs $1.80, but I'm not sure that he's gotten it either. In terms of medical comorbidities, he does have this clotting disorder. He has also a suspicious lung nodule or mass that needs to be followed up with a CT chest. We're trying to figure out how to get him to get that. It's pretty difficult because he doesn't have insurance. He's also having a lot of abnormal weight loss, which concerns me in terms of the mass. In terms of the treatment plan, I have a lot of ideas on this, and I don't want to necessarily, squelch all the potential ideas or thoughts. I'm going to basically point out a few things. One of them is co-ed treatment is not really part of the conventional wisdom for early stage recovery or substance abuse treatments. Usually have men, male or female treatment wings or facilities, and women tend to have a little bit harder time finding facilities, interestingly enough. And certainly I don't know of any co-ed treatment other than outpatient. I never really thought about integrated relationship counseling. One of the things that I read is that people with opioid disorder don't have a lot of social or interpersonal relationships with others. So you don't want to necessarily discourage the only relationship that they might have that's positive. And I have had couples that have come in where they're both either using alcohol or substances, and they've sort of encouraged each other and helped each other stay sober. So with that, I am going to go ahead and pause for a moment and turn it over for suggestions, questions, and criticism.
Thank you so much, Dr. Luckner, for presenting this case. I see a question here from Kristen in the chat. Has he been connected to an FQHC or charity clinic or pharmacy? Dr. Luckner, you're muted.
Sorry. So I'm not sure what FQHC is, but it sounds like it's some type of charity, because that's what the next question is. Maybe someone can comment on that. But as far as a charity pharmacy or clinic, I'm not aware of any in this area, but I'm certainly, if somebody has suggestions, I would definitely be interested, because there's a lot that's not being treated in this patient because he can't afford the medicine.
Yeah, this is Alicia, Dr. Kowalczyk. So an FQHE is a federally qualified health center. Hi.
Hi.
So I mean, you can Google search, but you're probably very aware of what free resources are available in your area, and it may just be kind of a desert for that type of research.
Yes.
But thanks, Dr. Clancy. I said she can look up by zip, so maybe y'all could connect on that.
That would be
I
great.
was curious about if he and maybe they are still, so I had two kind of questions, are still struggling. It looks like for the most part his OUD is pretty well managed with the buprenorphine, although the methadone, being in his urine, may be concerning. But is there any consideration, or is it even an option in your area for methadone and going to a full agonist, which I always get leery of going above about 4 films a day on the buprenorphine or above 32, because we really do get that ceiling effect. And my limited experience with it has been, when I have done that a lot of times it isn't that effective. And I see other use escalate, which, again, from a harm reduction standpoint, diversion may not be that big a deal, but when my patient may be using those extra doses to fund ongoing other use, that does become a big deal to me. And so I don't know if that's something you've considered, and what's available for your patient. So that was one question I had.
Right. So methadone is not available in this area. It's 60 miles away, and then if you don't have a reliable car, you can't get to it. And even in terms of buprenorphine, I've had people that have had to travel a couple hundred miles. So it's relatively new, and I'm really pretty much the only one who prescribes it in this area. So I would say that's a great idea, but unfortunately, I'm not a federal clinic, and
Yeah.
here.
Yeah.
As far as the
And that
ceiling
act
effect
hasn't.
goes, so I do suspect that there's probably diversion, but at the same time, it's from a harm reduction standpoint. I would like to get the girlfriend back into treatment. She was in treatment for a while, and then she sort of dropped off. So I'm trying to get her back in. So that's one of my goals. But yeah, you're absolutely right. I'm torn about the whole diversion thing, because it's just not something as a doctor that you like to see.
Yeah. I figured there was probably a huge barrier to methadone up there, because I know Suboxone's just now kind of getting out there with your work and stuff that you're
Yes.
doing. The other question I had was, I didn't hear anything about an assessment, or if there was, any exploration of if there is any interpersonal violence in the relationship on either direction. And it can often be under asked about with the male partner in a more heterosexual relationship. And if that's something you've explored, the safety within relationship, besides the safety of, maybe serving as triggers for each other and things like that.
That's a great question. And because I have treated her in the past, I do have some insight. She does have PTSD from things that have happened, but not from recent events. She's told me a lot. She told me a lot about the relationship before I ever met him, and it seemed like that was not part of it. I have other patients where that is a big problem, but this doesn't appear to be one of those. One of the things that I thought that I kind of I didn't even think about was whether buprenorphine would have a side effect in terms of erectile dysfunction or sexual dysfunction, and then also in women having some effect on sexual relationships. And at least now I'm going to ask. I didn't even think to ask before, but I wonder if that's why sometimes people use methamphetamine just to sort of compensate for that in some way. So that was one thing that I was really curious about, because I certainly don't see it in like Lexicomp as being anywhere near the top of side effects, but it wouldn't surprise me if it wasn't. And I know that opioids reduce testosterone, so I'm kind of curious whether buprenorphine does that in the long run. I haven't seen it as much in that case. Sorry, I didn't really.
Hey, yeah, I'd as far as testosterone and buprenorphine, my understanding is that it really isn't as much of a problem as methadone or other full agonists are at higher doses. So I believe it is more sparing with that. I have to I have to give you some props for trying to think about couples therapy with these two, but it's hard for me to think about how one would try to do that if one is often using. I mean, I'm assuming she must be using illicit opioids all the time. They're both using meth, I would imagine.
Yeah.
So really, I think the first order of business is getting people, in some kind of reasonable, stable shape. And it would, that this doesn't sound like the couple that's building them, each other up and help each other with their recovery. This is the more than half where they, end up influencing each other to continue using. So
yeah, this is probably the double decline. But I would say that I just had never really thought about the question. I just always, I knew the conventional wisdom was not to do it, and so I, thought I'd look into why don't you do it? And I've had couples where there was this positive reinforcement. This isn't one of them. I feel like this is a relationship where the sum of the parts is less than each individual.
at least in terms of recovery.
So, but one of the things that's a real issue is that they don't want to be in separate, they don't want to separate and go into rehab again separate. So that's kind of why I was thinking about it. But boy, it's a challenge.
I think the way I usually approach these things is like, listen, this isn't a permanent thing. How is she going to stop if you guys continue to use together? So
Exactly.
sometimes you can frame it as a positive thing for their relationship and their joint recovery by, somebody taking the initiative. Maybe it wouldn't work, but over a period of time, especially if things aren't going any better, then sometimes one person decides, okay. I mean, she may end up actually being the one that ends up going to rehab just because, sounds like she's probably doing that much worse. But I think giving a reasonable message over time, often times, patients may consider it.
Right.
You hope it doesn't happen after some, bad thing has happened. Somebody lands in jail or something like that.
Yes. No, I think, right now there is no co-ed inpatient sort of rehab type treatment that I'm aware of anywhere near here. But outpatient, I can do some. I never thought about doing couples therapy for medication-assisted treatment of opioid use disorder. I don't know that I'm considering it either, but at least I thought I'd look at the question.
I would say it has to be a very niche expert kind of treatment. I can't say I've ever read anything about it with people that are actively used.
Right.
Yeah.
I was wondering about your experience with his partner when she was on buprenorphine treatment on OBOT with you. Was meth still an issue once she was on, but did she ever stabilize?
So she did use meth occasionally when he wasn't in the picture. I guess he was dating someone else. But she would use it intermittently, and again, I don't know if that's because I never really asked a whole lot about the side effects of buprenorphine, other than, is it causing you to have constipation or things of that nature. I never really thought about, is it making you fatigued? Are you using meth to compensate for that?
Yeah. Much less likely, though, as Dr. King was pointing out, than a full agonist, which is what they're kind of, we're using they're now on instead. I haven't seen a lot occasionally, but yeah, much more common when I was working methadone to see that.
Okay.
That's an interesting thought.
I see a couple of questions in the chat. From the first one is from Daniel Sledge. How does he afford rivaroxaban? I'm sorry, I'm mispronouncing that name.
Yeah.
Is he getting samples, or is he on a patient assistance program?
I think his dad is paying for it. So his dad is giving him $300 or whatever it is to pay for that. And then he doesn't have any. He's having housing insecurity. They just got kicked out of their home because they never paid rent for the past 6 months. So I think it's a question of priorities. Like, what do you want to spend your money on? Housing or car or medications? And unfortunately, some people have to make those kind of decisions.
Right. And we have a couple of questions here from Barbara Montag. Is this patient eligible for Medicaid?
Usually young men, I don't know that they, during COVID, yes, but not currently. And then she's eligible for some type of insurance, which is why she's not in Be Well. But she had a surgery, but even for her, Medicaid, it's very, I don't see a lot of young, 41-year-old men that are on Medicaid, unless they have other disabilities.
Thank you so much. This has been a wonderful discussion. Before we close up, I thought, Dr. Walker, you had something to share. I saw you unmute at some point.
Yeah, no, I was just going to ask if you had access to the WeConnect app through Be Well, because that might be a way for them to, individually get some peer support and some extra wraparound services and some contingency management for the methamphetamine use issues, if that's a resource that you have to grab onto for the two of them.
Yes, he's using the WeConnect app, and she's used it quite a bit in the past. I don't know how much she's using it currently, but yeah, it's a great app, and it's one that I use even for people that are not connected to substance use. I'll have them download it and use the free version.
Well, thank you so much. This has been a wonderful discussion. And I will request Dr. Kowalchuk to provide a summary of the session, please.
Yeah, so we have a gentleman in his 40s who's on OBOT with buprenorphine for his opiate use disorder, and that's fairly well managed with the buprenorphine at maximal doses, but ongoing struggles with methamphetamine use disorder, and has a partner with ongoing struggles with opiate and methamphetamine use disorder, a female partner, and talking about strategies to keep him engaged, to possibly get her back into treatment, and that for some couples, there are opportunities for synergy in terms of getting into and sustaining recovery. And then for other couples, it does not seem to work out that way, that they can continue to spiral. And so this is a tough case to manage, particularly in a low resource, situation. that they both find themselves in, and in an area of relatively dearth of more intensive services to be available. And so, ongoing work through motivational interviewing, keeping the patient that is actively engaged in treatment, coming and in treatment, and perhaps over time helping them reflect on kind of if they're meeting their personal goals with the current status quo or not, may be eventually effective in helping them decide to maybe move forward separately from their partner if their partner isn't able to engage and get back into treatment.
Thank you.
Great case.
Thank you.
Apologize. Thank you again, Dr. Kowalchuk, and thank you to Dr. Lubner for bringing this case to us. And thank you all for joining today's ECHO session. As a reminder to earn a CE credit, so please text the activity code 1009 5737 to the number. The details are in the chat. Please, to earn your CE, we also request you to complete the post-session survey using the link in the chat. The survey will be open for 1 week. If you would like to present a case, please email cstat@uthesca.edu. Thank you and have a wonderful rest of your day. Bye-bye.